All right, Kathy, I'm going to explain
Oh,
menopause.
this should go well.
All right, I've done some research.
Okay, stop. I already know this is going to end with you saying something wrong, so I'll take it from here. We don't need mansplaining about menopause.
Okay, but I can tell you that mansplaining is when what?
You're stopping. Okay, so in menopause, perimenopause, for a lot of women, it feels like the body suddenly flips a few switches. Sleep changes, joints hurt, workouts feel harder, and you're randomly overheating like someone turned on a space heater inside your body. And then 5 minutes later, you're freezing. So you're asking yourself, am I sick? Am I dying? Or is this just perimenopause?
And historically, the medical system's response has basically been, well, that's menopause. Anyway, see you next year. So today we brought in someone who spends her entire career helping women navigate exactly this.
That's right. Today we're talking menopause, hormones, gynecology, and what actually works with Jessica Bell, who's a physician assistant with Samaritan Health and has just started her own business in addition to an already full-time job.
Okay, Kathy, this is the part where I say this.
Yeah, no. Let's get started. This is the pitch.
What happens when a chiropractor and a physical therapist get together to make a health and wellness podcast?
But chiropractors and physical therapists don't like each other.
Oh, think again.
I'm Dr. Kathy Lynch, physical therapist who likes to help people move and get stronger.
I'm Dr. Jason Young, an evidence-based chiropractor who uses humor just as much as adjustments to help people get better.
Welcome to the Pitch Podcast.
Remember, there's no I in pitch. Okay, welcome back. This is the Pitch Podcast. I'm Dr. Jason Young.
And I'm Dr. Kathy Lynch.
And this is our special guest who we're going to get to in just a second, but I have to do a little bragging about the podcast. Did you know that this is our last episode?
This is it.
Yes, this is our last episode of the year.
Yeah.
Because after this, we're going on to a little bit of a 1 year celebration.
Mm-hmm.
We've been doing this for a full year.
Yeah.
It's crazy.
Yeah.
Good. We now. Oh, thank you. Hey, everybody, shut up. I'm trying to get to my part. Okay, I'm trying to get to my part. So, we have thousands of followers,
Mm-hmm.
and just more than we ever would have imagined.
Right.
We were originally projected at being at dozens at this point, and I guess technically we do with just many dozens. So thank you to everybody who's subscribed. If you're hearing this for the first time and you don't want to be some sort of a loser anymore, just go ahead, hit the subscribe button. You could be one of the pitches, and you can join along with the show. So I just want to throw that out there really quickly because so excited to get to our guests. So take it away, Kathy.
Yeah.
Tell us who we have here.
Oh, well, I'm just super lucky to call Jessica a friend.
Does she call you a friend too?
Well,
Absolutely.
Okay, good. All right,
Yes.
good. Those are the best kind. Those are the best kind.
It's mutual.
It is mutual.
Yay! Okay, but let me get to the real deal about Jessica. So she's a board-certified physician assistant, licensed in Oregon, specializing in perimenopause, menopause, and sexual medicine. And she holds certifications, this is the important part, as a Menopause Society Certified Practitioner.
Whew, that's a mouthful.
It is.
Okay.
It is. But you need to, when you are asking questions about menopause to your healthcare provider, make sure they're certified.
Oh, yes.
Yes. And she's also a fellow of the International Society for the Study of Women's Sexual Health, otherwise called ISHWISH.
Ishwish.
Yeah.
Ishwish.
Yes.
Ishwish. Do you have to yell Kobe before you say Ishwish? Kobe. Ishwish.
She's a local provider at Samaritan Health Services in town, but also what's very exciting is she just opened up her own online telehealth medicine.
What?
Would you say it's not a clinic, but it's online?
Yeah,
Service.
Yeah, it's a service.
Yeah, called GynJess. So GYN Jess.
Okay, and we're going to talk about this.
We
Yes?
are.
Okay,
We
good.
are.
Awesome. Love it.
Yeah. So welcome, Jessica.
Yes,
Thank you.
welcome.
Thank you so
I'm
much.
so happy to be here.
She's the final compadre of the Novo Collective.
The Novo.
to join
We've
us.
now collected the
We've
entire
collected
collective.
them.
Oh my goodness. Well, these
Yes.
are always great episodes. So
Yes.
no pressure.
Yay.
No pressure.
No, this one's Jessica's gonna knock out of the park. It's gonna be.
You know what I'm impressed by? We have managed to lure so many experts.
I know.
And you kind of feel a little bad for them. Because they're like, okay.
I want to be here.
Yeah, oh,
Yes.
good. Well, we're so glad that you're here.
Yeah.
We're
Yes.
so glad that you're here.
Can you just kind of tell us, this is usually my first question, about your journey to get to where you are right now in your career?
Absolutely. Patience, really, truly. So when I started in gynecology 10 years ago, I had patients coming to me that had these constellation of symptoms that I now know were perimenopausal. I would admit that I did not necessarily back then. And they really inspired me to dig into this education. So that's when I went to my first Menopause Society conference, and then I went to my Ishwish conference, and now I'm certified. So honestly, just inspired by patients and their needs, I would say, from clinicians. And I'm just somebody that then digs in to get the answer.
Yeah.
If I don't have it. So
Yeah. What's it take to get that certification?
So to be a Menopause Society Certified Practitioner, I mean, basically what that means, I would say, is I spend all of my time listening to podcasts. I'm
Yes.
serious about
Yes.
perimenopause and menopause.
We knew you were a good person.
Legit though, reading books about perimenopause and menopause, reading all of the studies. My friends sometimes challenge me to like read something that's not about perimenopause and menopause. So that's the life of an MSCP. And then the certification itself.
You're like, this book is called Hop on Pop. You're going to enjoy it. You're going to enjoy it.
Yeah.
This Dr. Seuss isn't a real doctor.
No. Give me the menopause books, the perimenopause books, the sex med books, the history of the stuff books. And the podcast about them. But to be an MSCP, I had to go to a lot of conferences. So it's a lot of continuing medical education. And then a pretty difficult test, too, that I had to pass. So
yeah, we're establishing you as the expert.
Well, thank you. I do feel expert at this time.
Quick question.
Yeah.
I think, is she the first physician's assistant that we've had on the show?
Yes.
Okay, so we have to talk a little bit about that, because I'm sure that there's people that have questions about what a physician's assistant is and how is that different from, like, is it the same thing as a doctor or, okay. So break it down for us.
Yeah. So we are now called physician associates.
Oh,
right.
So physician assistant.
You didn't have to change the initials from PA.
No,
Okay, cool.
I think that was
good.
purposeful.
Okay. Yes.
But so a physician associate or a PA works very independently. So I work similar to a MD or a DO. So I see independent patients. In the past, we used to have a supervising physician. Now it's a collaborative agreement is what we have. So there's some limited scope of practice for PAs, but I can do all of the things that I want to do.
Yes.
And I also work in the operating room. So I would say that's a space where my role is definitely as a PA. So the physician in the operating room is the primary surgeon, and I'm the first assistant in there. So that's another way of we're different. But
cool. That's really good, because I think that there's a lot of people that maybe didn't understand the distinction. I know I refer back and forth with a lot of PAs, and they're really really good.
Yeah. I would say sometimes people might not even know that their doctor, quote unquote, is a PA. And anytime somebody tries to call me Dr. Bell, I will say I always correct them. I say I'm just Jessica.
I know.
I did not go to school that long.
I get a lot of referrals from one, and they're like, "Oh, Dr. So-and-so," and I just quit correcting them. I'm like, that is up to her if she wants to correct them.
Right.
But,
If I correct them like 1, 2, 3 times, and then after that, no, then you're just rude for correcting people.
No, but cool. Thank you for explaining that.
Yeah, and different than medical assistant. I think that's one of the things, and that's one of the reasons why we changed the name to associate. So sometimes when I say that I'm a physician assistant, people think that I'm a medical assistant, and that's definitely a different scope of practice.
Right.
So.
Yes, we love you, medical assistants.
Yes, we do. Oh my gosh. My medical assistant is the best in the world.
Shout out. Shout out.
She's now been on a podcast.
Yeah,
I know.
Yeah, because PAs can order imaging. You can prescribe meds.
Oh, yeah.
You can do a lot of the things
procedures.
that physicians. Yeah.
Yep.
Yeah. They're a lot of times the last person in the surgery room.
Oh, yes.
Closing things up.
Yes.
You're kind of doing the cleanup work.
Yep. We do a lot. Yes.
Yes, and that's why I'm not a PA.
Yeah. And there's reasons why PAs aren't doctors.
Yes.
Yeah.
So
there is that. Okay. So, so we kind of started to talk about why menopause.
Mhm.
So when did you start to see the shift into, actually, you know what? Let's go back to, why have we not learned about menopause up until this point? Really?
Mhm.
I
Mhm.
mean, if I remember correctly, I feel like you've told me in the past that we really didn't start researching menopause until the
Mhm.
90s.
Mhm.
Is that,
Mm.
am I remembering
Well,
that?
I think probably what we talked about is that we did not include women in randomized controlled trials. We
Okay,
also did
that's what it
not
was.
identify the full anatomy of the clitoris until the 80s.
Mhm.
1980s.
Wow.
Yep. And so I would say one of the reasons why I think in medical training there has not been a focus on menopause or perimenopause
Mhm.
is that we as a society are very focused on fertility
Yeah.
and reproduction.
Mhm.
And
Mhm.
so generally the
Right.
OBGYNs have been most of their training, I would often is in obstetrics. And I think that that also relates to why we also don't study things like endometriosis or,
Mm.
Mhm.
period syndromes of
Mhm.
people, adenomyosis, those kinds
Mhm.
of things. We're definitely behind, I would say, in regards to emphasizing the importance of general gynecology and hormone health throughout the lifetime.
Mhm.
I often say just because you have a uterus does not mean you're going to ever make a baby in it
Yeah.
or
That's right.
want to for that
Yeah,
matter
right.
either.
Yeah.
So
Nor do you have to.
Well, and some
Yes.
uteruses have different ideas about that.
they
Right?
do.
Mhm. Yeah.
It's so true.
Yeah, they
Yeah.
definitely do.
Yeah.
Like,
But right.
you might want one, but nah, we're
Yeah.
not
Yeah.
doing that.
Yeah.
Yeah.
We're not doing
Mhm.
that. Yeah.
Mhm.
So I have a question. So is that just in the U.S. there hasn't been much research, or is it worldwide? Are there some areas where they're maybe ahead of the curve on this, or
It's pretty much
okay?
worldwide, honestly. It was an
Because women
Australian.
women were a pretty recent invention.
Yeah, right.
Like
Yeah.
I think it was Jane Austen, didn't she invent
She
women
was
when
the
she wrote that
person.
book? Yeah.
That
Yeah.
was
Yeah.
her.
That checks out. Yeah.
Goodness gracious.
Yeah. No, I think it's similar everywhere.
Okay.
Yeah,
Yeah. Well, that sucks.
I know.
Yeah.
Totally.
Yeah.
We're all behind.
Yeah. Yeah.
Can we talk about the study? Yes,
Yes.
the study that
The study?
the study
I haven't
Yeah.
read the study.
the study that got us on the wrong foot with
Oh,
hormones,
okay,
hormone
yes.
replacement.
Yeah, the Women's Health Initiative study, which came out in 2002.
Mhm.
Yes. It sought to determine if a hormone therapy would be preventative in regards to cardiovascular
Mhm.
disease, osteoporosis. But one of the issues was the average age of people in the study was 63 years old. We haven't gotten around this yet, but the average age of menopause is 51. And so when they're doing a study regarding prevention, just the design from the
Yeah.
start was not that to look at prevention. If you want to look at prevention, then you should be studying people before menopause, not
So you
10
want to
years
study the ship
afterwards.
while the ship is still in port, not after it's sailed and it's just disappearing over the horizon.
Perfect analogy.
Okay, gotcha. Yeah,
Yes,
all right.
Yeah. So
I'm following.
yeah. So there was some study design errors. It had a lot of people in it, so I can't say that it was a bad study necessarily. But for one thing, it also was not asking the questions that we're asking now,
Mhm.
and it was not using the medications that we typically use now. So different age range of people that were curious about different chemistries. And what happened was the study was stopped because the estrogen progestin wing had a non-statistically significant increased risk of breast cancer.
Oh.
The estrogen only wing had a decreased risk of breast cancer. But
Mhm.
that's also a curious thing. We often say in our conferences and whatnot that there's no other studies that have been stopped for a non-statistical significance. So the WHI, I think, is the only one that was stopped for that.
Mhm.
Okay.
Yeah.
You know what? We forgot to just define what menopause is.
Yeah.
Let's start
Yeah.
from the
Let's do
beginning. Let's
that.
go.
Okay, shall I?
Yeah.
I defer to you.
All right.
Mhm.
Well, so menopause is 12 months without a menstrual cycle. Average age of menopause is 51 years old. But 45 would not be considered premature. So some people will have their last menstrual cycle at 45, which is much younger, I would say, than most people think.
Mm-hmm.
And I'm sure we're going to talk about
We
perimenopause
are.
today, which is
You
that
make it
10
sound
years
so
before.
exciting. the way
It's exciting because
Perimenopause. Let's go. Hey, ladies.
you want to know what's coming.
Can
Some
I
people-
interest you in perimenopause? No.
Somebody coined the term cougar puberty, which
Oh,
is like,
yes.
talk about a party.
I'm laughing about menopause.
Yes.
Yes,
Here we are.
Here I am.
Welcome to the party.
But yeah, perimenopause, 10 years before that last menstrual cycle. And that really is the volatile, erratic hormonal roller coaster that I think we are all excited about it because we're actually acknowledging and honoring it as an experience for people. I would say 10 years ago when I got into this space, I remember women coming to my office with severe perimenopausal symptoms, severe mood changes. And at that time, we were still taught to really not have a conversation with people until it had been a full 12 months without their menstrual cycle.
Wow.
So
Oh,
I just think, yeah.
like, let's keep this a secret.
Yeah. And
It's a surprise. They're
I
going to
have
love
no
it.
idea what you're
Yeah, they're
going
going to
through.
right.
in the past, we used to just tell people, get through that 7 to 10 years of volatile, erratic hormonal roller
Mhm.
coaster, and then let us know how it feels once it's been 12 months without a cycle,
Mhm.
and then we'll see how you're doing then,
Right.
which negates age 35 to 45, which is also, I have to say, for some women, a very important time in their life when it comes to maybe career or family and other relationships. So not the time to be experiencing a volatile, erratic hormonal roller coaster.
Just grind it out for 7 or 8 years.
Yeah.
You'll be good. You got
When you
this.
say volcanic, and it's like, I mean, this isn't just good for women, it's good for everybody, because have you ever stood next to a volcano?
Yeah.
Yeah. Not a lot of people who are alive have.
No. Yeah.
And that's all I'm going to say.
Yeah.
That's it.
Well, I mean,
Done.
it's no
That's probably all
joke.
you should say.
Yeah, it's no joke. These big hormonal changes do impact people in very significant ways.
Mhm.
So, and we can help them.
Yeah, let's get into that. Let's get into, what the symptoms are of perimenopause.
Yeah. So I would say, mood changes.
Mood changes.
Yeah.
Mhm.
Well, and we should preface this with, this is going to be a revelation to somebody listening. You're going to
Yes.
listen. You're going to be like, holy
Ah,
crap, that's what it is.
I
You know?
know.
That's
so-
what I'm going through.
Listen up.
Yeah.
Listen up. So
Yeah.
sorry. So mood changes.
I know, and that's why I say it that way, because I have to admit, even in my late 30s,
Mhm.
this is something I study. I don't think I realized
Mhm.
how perimenopausal I was until I realized I was perimenopause. And the mood changes that happen for women in their late 30s, the irritation, agitation, pressure cooker feeling, short fuse, the sense that they rationalize that they're not rational is really significant. So that's the big thing. And yes, I'm very excited for that person that's listening right now
Mhm.
that is feeling validated in their experience. It's also true. I often say, the world is happening always to us and stress is happening, but through these hormonal fluctuations, what occurs is it makes it more difficult to navigate those life stressors because hormones are just on their wild roller coaster. So mood changes, definitely. Hot flushes, night sweats, sleep disturbances. There's kind of a classic waking up at 2 or 3 a.m. that happens for people. Brain fog, difficulty finding words, difficulty multitasking. People are reporting a new onset or worsening of ADHD symptoms. Musculoskeletal symptoms.
I might be perimenopausal.
Joint pain. Absolutely. Right. Yeah. Andropause is a thing. Hip pain. That person listening right now.
Yes.
Mhm.
Yes.
The hip pain that happens at night is oftentimes related to hormonal fluctuations. Skin changes. People will notice dry skin all over. And then irregular menstrual cycles
Mhm.
also.
Well, and that's typically the only thing that people think about. Is,
Yeah.
oh, my cycle's changing.
Yes.
Right. But it's
And
but there's all that other stuff.
All of those things that I just listed can be happening while having a regular menstrual cycle.
So you're still having a regular cycle. So you don't even I didn't know I was going through perimenopause now that I
Mhm.
look back. Like
Mhm.
I mean, I was at night sweating through my clothes,
Mhm.
waking up at 2 or 3 and having to change my entire outfit
Yeah.
and go back to
Mhm.
sleep.
Mhm.
And I was like, I don't know what's happening.
Why is the difficulty level turned up to 11 on this?
Yeah.
Yeah, geez Louise.
Yeah. Yeah.
That's
It's
quite the
intense.
list.
Yeah,
Mhm.
intense,
Yeah.
volatile.
Very.
Mhm. Yeah.
Yeah. So, that's if you're experiencing these things and you're in your 30s
Mhm.
and 40s, it's perimenopause.
Mhm.
Don't be in denial.
And one of the things I like to point out too is that, again, not all of us get this training or education. So, one of the places
Mhm.
where a lot of people are left untreated or their symptoms are left unheard is in the context of this constellation of symptoms, but irregular menstrual cycle. So,
Mhm.
this is the scenario where they go to their PCP or honestly, even their general gynecologist, and they tell them all of these things. And they say, well, how's your bleed? And they say, well, it's regular. Okay, well, then it must be something
Hey,
else.
come talk to me in a year.
Yeah.
Yes.
Yeah.
Yeah.
Grind it out.
So
Mhm.
you've said it twice now. You say
Mhm.
constellation of symptoms. And
yeah.
whenever I was like getting my education, I
Mhm.
learned that a constellation of symptoms is also another name for a syndrome.
Mm.
So would you call it like perimenopause syndrome?
Yeah. Are we calling it that?
Yeah.
I don't know.
Perimenopause and menopause.
Yeah.
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 Syndromes.
I don't know.
We
Yeah.
could.
But I don't know
Coin
why that's
right here.
important to me. But
Yeah.
that just
That makes sense to me
yeah.
too.
Mm-hmm.
But maybe it's not a syndrome because we all go through it. All women go through it. I don't know.
I don't
Now
know
we have to
either.
look at the
I don't know either.
definition. Yeah.
Right.
Wow.
If it's not in the literature, get publishing.
There you go.
Get publishing.
Yeah. Yeah.
Yeah.
That's right. What most commonly, what do patients come to you and ask
Mm-hmm.
when they're going through these kinds of
Mhm.
things?
I think the most common question is it too early?
Yeah.
Dude, yeah, that's the question I get all the time
Mhm.
is it too early?
Yeah.
They're 37 and they
Yeah.
have checked every box of the list that I just
Mhm.
said, but their cycle is regular. And I'm like, babe, no, it's not too early.
Yeah. Does anybody ask if it's too late? Like-
yeah, they
Actually,
do.
yeah.
Yeah,
Like
that's
it's like
what
they're
I
like
get.
the lady on Titanic.
Mhm.
It was 81 years ago. Is it too late for?
Oh, that's happening all the time
Is
right
it
now.
really?
Oh, yeah, there's big conversations about perimenopause and menopause. And so a lot of the women that were caught in the Women's Health Initiative study
Mhm.
have felt left out of
Mm.
this as an option. And so I do have people that are maybe past an age where they would find a lot of preventative benefit from the medication,
Gotcha.
but they might still find symptomatic benefit. And then we get to have a conversation regarding risk benefit
Mhm.
ratio, because sometimes there can be clotting risk associated with starting maybe hormone therapy at a more advanced age, I would say.
Mhm.
So, yeah.
So hormone therapy, can you explain that? Is
Mhm.
that just a fancy name for taking some estrogen?
Oh,
Or
yeah.
like
Mhm.
what's involved in hormone therapy?
Uh-huh. Well, hormone therapy could be a lot of different things. Birth control, I suppose, could be considered hormone
Sure.
therapy. Probably right now, the conversations around hormone therapy, though, that we're hearing is regarding the body similar or bioidentical forms of hormones. So, estrogen and progesterone, and then testosterone is also a hormone that we're using for menopausal
It's
symptoms
becoming
as
more
well.
popular, I
Mhm.
hear. Like
Absolutely.
I'm actually kind of surprised at the number of patients that come in
Mhm.
and they're like, I'm taking testosterone.
Yeah.
Mhm.
And it's like, are you trying to transition? No, it's like
Yeah.
it's because I'm perimenopausal. So
Absolutely.
okay.
Yeah.
Mhm.
Yeah. Testosterone declines in women just like
Mhm.
it does in men. Did you know that a 6-year-old man has more estrogen than a 6-year-old woman does?
Wow.
I did
So,
not.
I did
yeah.
not.
I
So
call
there's the
6-year-old
part
men boys.
there's the part where hormones aren't
Uh-huh.
gendered,
Wow.
right?
Yeah.
Yeah.
Mhm.
Yeah.
Oh.
So
Yeah.
I think that that's a bit of, oftentimes a misnomer that testosterone is for males and
Mhm.
estrogen is
Mhm.
for women.
Mhm.
But testosterone declines in women too and can contribute to decreased energy, decreased exercise tolerance, stamina, decreased
Mhm.
libido.
Mhm.
We're starting to study the benefit of testosterone in regards to muscle mass
Mhm.
and muscle wasting, which
Mhm.
happens. We know that estrogen helps prevent osteoporosis in the future. And so we definitely hypothesize that testosterone can help with muscle wasting, similar to in male-bodied people too,
Yeah.
who use testosterone
Yeah.
for health,
Sure. Yeah.
measures. So yeah, women
Mhm.
are finding they can do the same thing.
I had a patient who told me, "You gotta get on the T, dog." I was
Yeah.
like, "I got."
Are you low
I'm
T?
sorry, what? I don't even know, but like this guy was, and he's like, "Yeah, you got to get on the T."
Oh,
And
lowering the
I'm
voice.
like, well, and the thing is, his voice is normally like this, but when he says it, you got to get on the
Oh,
T.
yeah.
Yeah, dog.
Yeah, yeah.
Yeah, it's like,
Yeah.
oh my gosh. So,
Yeah.
wow. Can I ask one more question? Because
Please,
you
Yeah,
please.
had,
all the questions.
yeah,
Inquiring minds.
things are just popping in my head. So, we live in a crazy world because of social media.
Mhm.
And there's like lots of influencers out there and people who think that they have education about this. And maybe they don't have much, but what they really have education in is a supplement that they want to sell or
Mhm.
something like that. So, can you comment on how, like, some of the relative dangers of working with somebody who thinks that they understand balancing female
Mm.
hormones or anybody's hormones,
Mhm.
and they don't know what they're
Mhm.
talking about?
Yeah.
What are the dangers?
Yeah. Well, that is a scary space, I would say. Not everybody has the education, the Menopause Society Certified Practitioner education
Mhm.
to be evaluating and I would say prescribing the right treatment recommendations.
Mhm.
So I would look into their credentials. Nowadays you can Google the person
Mhm.
and
Mhm.
find out about them before you trust them with your health and your hormones,
Yes.
please.
And I
Yes.
think we were saying that it almost doesn't matter what the first letters behind somebody's name are,
Mm,
right?
Mhm.
It could
absolutely, yeah.
be MD, DO,
Mhm.
DC,
Mhm,
DMD.
mhm,
If you're talking to your dentist about balancing
Yes.
your hormones,
mhm.
I don't know.
Yeah.
But yeah, it's pretty specialized, especially
Mhm.
since I was shocked to learn that the research is also young.
Mm.
So young.
Unfortunately, there's a lot of profit over patience in
Mhm.
this space right now
What?
too. Yeah. Yeah, and excellent, clinicians that are board certified can sometimes find themselves maybe in that trap or whatever
Yeah.
that is, the profit over patients trap. And
Mhm.
I think sometimes promote supplements or treatments that aren't necessarily evidence based. When I consider, and they might say to that, well, it's not harmful. And that might be true, but I consider economics,
It's
Yes.
not
when
it's not hurting me, is what it is.
yeah. Or a certain therapy that doesn't cause a true medical harm,
Mhm.
Right.
but we don't have the data that says it causes a true
Sure.
benefit.
Mhm.
Sure.
Then what
Mhm.
I say to that is that when I consider the risk benefit ratio, I also consider somebody's pocketbook.
Mhm.
I
Yes.
consider their economics. Like that's
Mhm.
important to me.
Mhm.
So
Mhm.
mhm.
So let's go back to the study, the Women's Health Initiative. So 2002. Okay.
Mhm.
Jessica kind of alluded to it that they actually stopped the study
Mhm.
because what their conclusion was, and we know now that it was a faulty conclusion, was that hormone therapy caused breast cancer, basically.
Mhm.
And that's where everything stopped. And that's where the press kind of stopped too. And they ran with it.
Correct.
And that scared doctors
Mhm.
into using hormone therapy for people in perimenopause, menopause.
Correct.
Yeah.
Yeah. Yeah. Yeah. The study, I mean, like the whole world had a hot flash. Everybody stopped their seriously. Everybody stopped their hormone therapy at once. And it's taken years and years for providers to feel confident prescribing the
Mhm.
medication again. And
Mhm.
it's also so interesting because it's not even apples to apples. I will often use
That's right.
analogies in my visits. So sometimes I'm like fruit. Apple, banana, kiwi. They're all fruit. They are not the same thing. Estrogen.
Yeah.
High dose synthetic estrogen in birth control pills. Not the same as the estrogen we get from horses. Not the
Mhm.
same as the body similar estrogen that we are using nowadays.
Not
And
the
that
same
really
as
is
soy.
important.
No.
No. And that really is important because the
Mhm.
chemistry, the
Mhm.
is totally different. And I really
Right.
geek out on mechanism of action and
Mhm.
chemistry. And so
Mhm.
that is is a big issue, I would say, with leaning on the WHI to direct our treatment recommendations or to stay fear-based around it, is that we're
Mhm.
not talking apples to
Right.
apples. We're talking about body-similar medications now. And it is important to consider those in perimenopause in
Mhm.
particular. Again, that is that 7 to 10 years before the last menstrual cycle that is very volatile and erratic, and the time I would say when people need hormonal support more than ever. I mean, they likely need it postmenopausally, but
Yeah.
before too.
And so in that study, they were using synthetic.
Yes,
Yeah.
correct.
Mhm.
They were using conjugated equine estrogen, which we get from pregnant mare
Mhm.
urine, and then synthetic progestogen.
Yes.
So it wasn't all natural, so it was definitely dangerous.
Yeah, right. Well, yeah, and that's also why sometimes there's conversations around the word bioidentical
Yeah.
with with the hormones that we're using.
Mhm.
I tend to use body similar
Yeah.
because it's still made in a lab.
Yeah.
Mhm.
Well, and we
Right.
should clarify that not like natural does not automatically equal dangerous.
No,
Just the
yeah.
same as natural
Mhm.
things like arsenic
Mhm.
Yeah.
and, brown recluse bites.
Yes.
Those aren't safe.
Correct.
No.
Right.
They're natural. They're not safe.
Yes,
Mhm.
exactly.
Yes.
Exactly.
Mhm.
So,
It's natural to go through perimenopause and menopause, and
Mhm.
you don't have to suffer.
okay, let me
Yes.
ask you this.
Yes.
So, let's see, who was it? Um, it was, oh, geez, who was the Thigh Master lady?
Suzanne Somers?
Oh,
Suzanne
yeah.
Somers.
Yeah.
Okay, talk to me about Suzanne Summers. And you know what I'm at, because Suzanne Summers was really big about,
Mhm.
what was it like? Was it keeping your period your whole life or stopping your period? I can't remember what it was,
I am not
but she
familiar.
was, yeah,
Mm.
she was out there biohacking before it was
Mm.
cool. And like, should that be the goal? I think it was that, I think it was that she was like, yeah, you should keep your period your whole life.
So that I think some people are trying to research how to not go through menopause.
Yes, that's what it
Oh.
was. Yeah.
Yeah.
Mhm.
How to
Well,
not age.
yeah.
Everyone's trying to research that.
It's basically it just takes a thigh
Yeah.
master and that's it.
Gross, yeah.
Yeah. Mhm.
Yeah. Mhm.
Goodness gracious. So would there be an advantage to that or
I think that opens up a lot of questions.
okay, yeah. Because
If we all of a sudden don't age.
yeah. Yeah.
Yeah, that's a scary prospect.
Yeah.
Too, right? Are we gonna live forever?
Mm-mm-mm.
Okay, so when someone comes in with these kind of symptoms,
Mhm.
well, take me through that. If I came in and said I got all these things, I check all the
Yeah,
boxes.
yeah. So the first thing is I listen to you
Mm.
and I believe you.
Hmm.
I say
She
it like
sounds like a
that.
good one.
Yeah.
I know. Well, it's funny when I hear, I don't know, people talk about our encounters together. One of the things they're always so surprised at is that I listened and I
Yes.
believed them.
Mhm.
And it is surprising to me that that's not how every encounter with a
Right.
clinician is.
Right.
So,
It's disappointing.
yeah, honestly, I start the visit by saying, there's a story that brought you into this conversation. And I'd love to take a minute to just listen to your story to
Mhm.
start. So, and then I, can ask my questions kind of
Mhm.
thing. But yeah, this is very much a pretty significant lived experience for people. So I like to give them the space to just tell me what they've been through.
Mhm.
And then, I ask all my questions, all my history
Mm-hmm.
questions. And then we talk about options. Sometimes I might do some risk stratification. So, depending on what the treatment option is. And then, yeah, we initiate treatment, make sure that I have a 3-month follow up typically scheduled with them. You always want to follow up with your people and make sure that things are going well. Uh,
Yeah.
Yeah.
So say someone has a regular, cycle, but say they have all these symptoms. Are they a candidate for hormone therapy?
Absolutely. And it does not need to be birth control pills.
Right.
Yeah. That's another thing that happens. A lot of the times a person, they're 38, they have all of these symptoms, they're still having a cycle,
Yeah.
and they might be offered a birth control pill, which is an option,
Mm-hmm.
particularly if their cycle is getting cruel on them.
Mhm.
But that one of the things I am the gynecologist that honors that for some people, birth control can cause mood changes. It can also decrease libido by mechanism of action. We
Right.
see that. And it for some people can also contribute to some weight concerns.
Yeah.
And oftentimes when we're coming in with these symptoms, we don't need mood changes, decreased libido, or new weight
What?
concerns. And so birth control pill is usually not my first option. So I usually go with a body similar estrogen patch, and then the body similar progesterone if they've got a uterus. I do always start with a patch, now a transdermal route of administration,
Mhm.
to make sure that we are decreasing any risk of clot. Transdermal estrogen does not increase clot above baseline. So if a person had a history of clotting disorder or a history of clot, they could use that medication.
And that's the main advantage of the patch.
Correct.
That's
It's
great
absorbed
to know.
naturally.
I get that question a lot.
Yeah.
It's
Yeah.
well, a
Oral
lot is
estrogen.
relative.
Yeah.
Yeah, but
Yeah.
I do hear that questions. Why are they doing everything with patches and creams and stuff like that? So transdermal's a bit safer.
Yeah, oral
Okay.
estrogen has to be processed by the liver and the stomach
Mhm.
first. It has the first pass effect, so it can increase clotting risk slightly above baseline.
Gotcha.
So the transdermal routes are nice. They provide really steady state release of medication, absorbed into the body most naturally. One of the things we're starting to maybe consider more too is a lot of people are starting to take GLPs, which can cause some slowing of the gut. So we are starting to ask the question if our people that are using hormone therapy and are on GLPs and it's oral, is there some kind of getting eaten up,
Is there an
and are they
effect?
not
Yeah.
getting the results they could get from the medication? So
And also explain to our listeners too why you have to pair estrogen and
Oh,
progesterone.
yeah. So, a person with a uterus needs to use estrogen and progesterone for what we call endometrial protection. So, if you use estrogen only and you have a uterus, the endometrial lining can thicken inside of the uterus, which can cause concern. And so, you have to use both, or have
Yeah.
an IUD. An IUD is a
Mhm.
good option as well for endometrial protection. Honestly, IUDs are amazing tools in the perimenopause land because they treat the intolerable bleeding pattern. They serve as endometrial protection, protect against endometrial cancer in the future, provide contraception if needed. And you can still use your oral progesterone. That's another little pearl today.
Okay.
Not even a lot of clinicians don't know this, but you can use an estrogen patch, have an IUD, and you can still use that oral progesterone nightly, which can help with sleep, mood, and hair thinning, people think too.
Interesting.
I've seen this with a lot of social media influencers, encouraging people to go get their estrogen tested. Can you talk about that?
Yeah. Yeah.
Yeah.
Another misconception. Yeah.
Well, again, there's a big profit margin in perimenopause and menopause, and I think some really well-intentioned people are making profit off of that. So right now, our data does not recommend checking estradiol levels because it is this volatile, erratic hormonal roller coaster. In my visits, I always draw this picture to my patients where in the beginning, it looks like an EKG. I'm like, hormones go up and down each month.
You warned us that you were going to do this.
Yes.
Yeah.
Here it comes, everybody.
We feel good. And then just before the bleed, we feel really bad.
Yeah.
And then perimenopause happens, and it's like this huge, volatile, erratic hormonal roller coaster. And that is estrogen. So that's why we don't check estrogen.
Because it's not as meaningful.
It
Oh,
might
gotcha.
be 200 one day and 12 another day. And that's where oftentimes people go wrong. So they go see somebody, they have this constellation of symptoms, they get their labs checked, and they hear back from their clinician, well, your estrogen is normal.
Yeah.
Like, I knew that before
Yeah.
you did the lab,
Yeah.
actually.
Yeah.
So let me ask you a question that might seem kind of basic. So is the primary goal of the hormone replacement therapy to control those perimenopause symptoms, or is there another kind of underlying goal that is like protective or for health, like avoiding
Good
cancer or anything
question.
like
Yeah,
that?
yeah.
Every once in a while. Like
Yeah.
it was about
That's the
4
one.
episodes.
Yeah.
It's about 4 episodes since I
And
asked
you
a good
got
question
one.
and I saved it up. Yeah,
You
I was
did.
sitting here. I was like, do it, Jason. Do it. Do it. Come on, man.
Yeah, it's both. So you can feel better on a daily basis,
Okay.
and you can think about your future self too. It's not all hormones. We'll talk about that at some point. But when it comes to hormone therapy, that medication does create a more even keel space to navigate life through. So mood improves. Hot flashes, night sweats get better. The sleep disturbances go away. Energy gets better. People's skin gets better. Their hips don't hurt anymore. And then their future self might be thanking them too. So I often say, like, the 80-year-old you
Sure.
could be very happy that you are being
Mhm.
intentional about weight training,
Yeah.
using hormones to prevent osteoporosis.
Right.
We also see that hormone therapy is a tool for cardiovascular disease prevention if started in perimenopause or within 5 to 10 years. It's not what we call primary prevention.
Right.
That would be like exercise and don't
Yeah.
drink and
Like
smoke.
living a good
Yeah,
life.
yeah. But estrogen can be helpful too. It helps keep the arteries and veins soft, which allows the blood to move more freely.
And I imagine if you already have like some sort of genetic predisposition or some of those markers, that's probably just another plus. So would you recommend something like this even for, because I know there's probably some women who's listening and they're like, oh yeah, I've got some of those, but they're not bad, and it's
Oh,
not real
no,
serious. It's
wait,
not affecting my life
sister.
too much,
Yeah.
right? Or maybe
No.
they just have one system or
Sister.
two symptoms or two symptoms. Would you still recommend that somebody explore this or
Absolutely. I just really would. And now that we're starting to do some studies to ask the true preventative questions, if we do start this medication at 35, can we prevent that osteoporosis we were looking at in the WHI? So, but from a clinical experience and a lived experience, I would say do not wait. We do not need to wait for things to be so bad. And P.S. getting in to see somebody to have a conversation about this might take 6 months.
Oh, yeah.
And in 6 months, your experience could be much different.
Yes.
So
Okay,
I would say don't wait. Yeah.
let me ask one more question for the conspiracy theorists out there. Aren't you just a big pharma shill?
Yes.
And you get some
bonuses,
sort of
kickbacks?
kickback, like not as big as we're paying you to be on the show, but like aren't you just a shill for the pharmaceutical industry?
No.
No,
I'm not.
Oh, sorry, ladies. You hear that?
Shoot.
Oh,
Yeah.
man.
And
You're going to have to get off Reddit.
Yeah.
Oh, dang.
Yeah. And I would say too, I do prescribe FDA approved medication. So that is big pharma, but some people are prescribing kind of proprietary compounded medications, which do have a financial incentive and maybe not the same quality to them.
Sure.
So no, I'm doing this because I love this work, and it is really rewarding to see somebody feel better. We live 40% of our lives in this other hormonal state. So it's also not just like one moment in time. It's not one day is menopause. It's like one day is menopause, and then the rest of your life you're postmenopausal. So yeah. So I do it because I love making people feel better. I'm a really good people pleaser.
I've got one more good question. I don't know if this is a good one. I don't know if you've done like I joked at the beginning that I've done my research, right? Which if people didn't catch the joke, when you say I've researched this and it's something with healthcare, you haven't researched it. Okay. You've read some stuff about it, but I wonder, have you ever been involved in any research? And if not, like if you could pick a topic or a study to do, like just hypothetically, what would your research project be in this kind of arena?
Yeah. Oh, genitourinary syndrome.
Oh, yeah.
Yes, we haven't talked about this yet.
We're about to.
Yes, we are.
Yeah.
So there's a low estrogen effect that happens. I can say all anatomy words, right?
Yeah, all of them.
Vulva and vagina.
Yeah.
Penis.
There we go. There is a low estrogen effect that happens at the vulva and the vagina that can cause symptoms of urinary urgency, frequency, light incontinence, itching, burning, decreased lubrication, decreased sensation, decreased arousal, etc. Also lead to pH changes that contribute to urinary tract infections. This
Which
happens.
UTIs are more dangerous than people realize.
Absolutely.
Yeah, it's crazy.
Totally. Yeah. For sure. In
Mhm.
fact, so it turns out vaginal estrogen can help prevent urinary tract infections. It's the first line treatment for preventing. I actually know somebody that did a study on like how much money could we save the healthcare system by just putting people on estrogen cream and preventing ER visits and hospitalizations. It's a lot.
Yeah.
Yeah.
And
Probably
Vag-
starts with a B.
yeah.
Bazillions.
Bazillions.
But this happens also at very young ages, and a lot of times girls don't know this. So this can happen. There's something called hormonally mediated vestibulodynia, which
Ooh.
is a side effect of systemic birth control. So some young girls are put on systemic birth control pills, which they
Interesting.
might definitely need for a million reasons.
Right.
Hooray for reproductive health. But it lowers the hormone impact at the tissue level. And so they are sometimes diagnosed with a bladder pain syndrome. And it is actually this low hormone effect that
Sure.
causes
Kind of
a
a side effect of
hypertonic
that.
pelvic
Gotcha.
floor. Exactly. And it
Mm.
goes dismissed forever. And you can, and then, I mean, it's just this big downstream effect. You think of this 15-year-old girl, she's on a birth control pill. She gets UTIs or is having all of this pain. Maybe her first intimate encounter is also very painful. That I've seen lead to a relationship distress.
Yeah.
I had one person who they weren't sure if they were going to be able to conceive because of the discomfort. It was all due to her history of birth control use
Gotcha.
and this low hormone.
And that can be mitigated, though.
Yes. So you can put them on estrogen cream. So honestly, I think that we need to see what it looks like to put people. If you get your birth control pill prescription, you get your estrogen cream prescription too.
That's the study that you would do.
Yeah.
That's really interesting.
Absolutely. We don't need to. We do this thing where we wait. We
Till
wait
it's so
until
bad.
it's so bad, and then we're like, oh, okay, here you go. And because this also happens in perimenopause and menopause.
Yeah.
But what happens is these tissue changes occur. We wait until a woman tells us in an encounter that she's experiencing pain with intimacy. Well, she's been experiencing pain at this point for many years. You know, and maybe, and we waited for her to bring it up.
Yeah.
We didn't even ask the question to her. And that could have been prevented all along. So in my encounters, I'm like, here's your estrogen cream. You don't need it yet, but we don't need to wait until things are so painful and uncomfortable. You're getting infections and you have this constellation of symptoms. You have a syndrome for us to say, oh yeah, it's kind of like, I often use the dentist analogy. We don't go to the dentist without ever brushing our teeth, like with cavities. And then the dentist
That's
is
not
like,
normal?
here's the toothpaste that was going to prevent that all along.
Right.
You know? So yeah.
This is so interesting. And thank you for sharing this because like I'm just having light bulbs go off because, you know, really commonly what goes along with that is low back pain, pelvic pain. Those are patients that I see all the time. And it's, you know, these are questions that are on the intake and I've never connected the dots.
Yes.
And so, that's given me a lot to think about.
Yeah.
Oh, was this somehow an intervention that you pivoted? Hey, listen, start.
Start asking.
But that tissue issue is kind of like a rash or a burn.
Yeah.
And then the muscles underneath become
Yeah.
reactive.
Yeah.
And then, you know, the bones and stuff.
And it looks like a sacroiliac joint problem that we can't fix.
Yes.
Yeah. Oh, that's
and
so
if you
interesting.
don't treat the rash or the burn, then you're not going to get any, you know, you're not going to make much progress at the musculoskeletal level if there's like a rash or burn that's there the whole time.
Oh, that is so cool.
Yeah.
And I know that people, they worry about going on birth control because they're like, why are you worried about it? Because of the side effects. Which side effects? I hear there's side effects. And so, but that's
and nobody
the thing.
talks about that one, though. That's the thing that's also frustrating is that, I mean, you pretty much have to be an Ishwish fellow in the
Mhm.
sex medicine space or menopause space to
I don't know a
really
lot
know
of
about
those. I
that.
met my
Yeah.
first one today. So,
Yeah.
yeah.
There's not a lot of us. Actually, I think I'm the only MSCP and Ishwish fellow in Oregon.
Holy
Wow,
smokes.
there you
Okay.
go.
All
One
right.
of a kind.
Mhm.
One of a kind. Yeah. Oh, geez.
Okay. So I had a question in my menopause brain. Just let it go right out. We're
Is this
experiencing
a
it.
symptom?
Yeah.
In real time?
In real time.
Yeah.
In real
It just
time.
came. Well, I guess one of the other questions was, are there quote unquote bad side effects to the bioidentical
Mhm.
estrogen and things that you can prescribe to people?
Mhm. Um, Honestly, estrogen for most people just helps them feel better.
Right.
I mean,
Yeah.
it's really the way it is.
Mm-hmm.
We felt good when we
Mhm.
had estrogen in our bodies,
Yeah.
when we were, cycling more regularly. And that happens again when people go back on, when people are supplemented with it. The person that does not have a good experience or might have too high estrogen is somebody that reaches out and describes too many cups of coffee energy.
After they take it. Yeah.
I do hand things. I kind of like have to do this every time I say it. Like, I just don't feel good is kind
Yeah.
of what they
Yeah.
say. Kind of an amped feeling.
That's that ADHD type of thing that you were talking about.
Well, that's kind of different.
Oh, this is different.
Yeah,
Oh, my
this is
goodness.
an estrogen side effect. So if
Okay.
I start somebody at a certain dosage,
Oh, right.
yeah,
Yes. Okay.
Yeah,
Yeah,
yeah.
I'm following now.
then they're like, I don't think it's right for me. And I'm like, what's going on? Then they say, I feel like I've had too many cups of coffee is an estrogen side effect.
Mhm.
Progesterone, the body similar progesterone. I often say there's like 3 camps of progesterone. The first one is I've never slept better in my life until I
Yeah.
started taking Prometrium 100 milligrams nightly. Hands. The second one is neutral, like they don't know what all the fuss is about.
Mhm.
And then the third one is side effects, which is a pretty small percentage of people. But that would be somebody that felt groggy the next morning, had a new breast tenderness or a new bloat.
Mm.
Or I've had some people that say that it gave them weird dreams. Most people are progesterone lovers. One of my favorite things to do, honestly, is that person has an IUD that's been on an estrogen patch only
Mm.
and never been offered oral progesterone because they don't need it for endometrial protection. To give them a trial of medication of progesterone is usually a beautiful thing. It's often a missing piece to their puzzle. They sometimes notice more clarity. We're finding that progesterone decline can be a contributing factor to some of the severe PMDD that people start to experience in perimenopause and some of the maybe new onset or worsening of ADHD as well.
Mm-hmm.
Mhm. Yeah.
So interesting.
Right. And since I started working with Jessica and friends with her in the
Mhm.
Novo Collective,
Mm-hmm.
any woman that comes in that is in their 30s and above, if they have these pains that they describe to me, my first question is, okay, what's your menstrual cycle like? Where are you with perimenopause? And a lot of them are like, I don't know. I have no idea. I have a regular cycle. And I said,
Mhm.
well, you should probably check with your gynecologist. Check on the hormones. And I kind of, now that I'm educated
Mm-hmm.
as a PT, I can educate them. Like, go back to your doctor, ask about these certain things, tell them that you check all the boxes for these things, because some of this pain you might be having may be just hormonal,
Mm-hmm.
Yeah.
and they're like, really?
Mm-hmm.
I say, yeah. I mean,
Well-
we're going to try to work on it in PT, but I also say, hey, you got to go check this with your doctor too,
Mhm.
as well, because you have too many of these symptoms for it to be just musculoskeletal.
Absolutely. You're a whole person. And yeah, I
Mhm.
get referrals sometimes from orthopedists
Mhm.
and that are like, we've done all the imaging, we've done
Yeah.
all of the things. The hip pain is
Yeah.
not improving.
Yeah.
Well, and
Estrogen.
I'm
Yes.
imagining you probably just based on your level of knowledge. I'm picking up
Picking
that
up.
you are
Yeah.
some sort of an expert.
Yeah.
I imagine you're probably getting referrals from gynecologists too, because
yeah.
I know of somebody who has recently gone to a gynecologist, and the gynecologist is like, so what do you want? Do you want like a hysterectomy? Like we could leave the ovaries, or like, do you want us to just like scope around and go looking for some endometrial cells, or like, whatever you want. And it's like, and this is a young person, right?
Mhm.
Who's thinking about like, do I want to have a family? And,
Mhm.
you know, and what does all this mean? And so it sounds like that's probably somebody who should be talking to you
Yes.
and not the gynecologist. It's just like, when can we get you booked to like start removing pieces?
Yeah.
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 Geez, that's
Mhm.
crazy.
Right.
Mhm.
It's
Well,
mind-blowing.
and that's, I think, one of the things you're speaking truth to is that as consumers of medicine, we don't always know
Mhm.
what a person's bank of knowledge is. You know, we would assume that an OBGYN would be a menopause expert,
Yeah.
and they're not, and they often will admit that that's the case too. Yeah, so
Yeah, we all remember that person from that class, right? Like, I got
Yes.
somebody from chiropractic school who they cheated their entire way through it, and like now I see them and I'm like, I look at their business and I'm like, bro, I remember you getting caught cheating so many times. Like, if only these people knew, but I don't know.
I
Can't
have
really blow
had
'em up.
patients tell me, and I'm sure you've heard more nightmarish than what I've had. But one patient told me recently that they asked their gynecologist about hormone therapy, and this physician said, "Oh, it's just a trend. This is
yeah.
just a trend. It'll fade.
It'll pass.
Yeah.
Just wait long enough,
Grind it out for
and
10
the hormone
years."
therapy will go away.
Yeah, and I'm sure you've
promise.
heard
Oh, I mean, every
worse
day,
stories.
multiple
Yeah.
times a day. The amount of times that patients have said, like, thank you for listening.
Mhm.
Thank you for
Mhm.
believing me. I have
Mhm.
told so many other people this, and you're the first one that
Mhm.
has listened to me. It's,
Mhm.
that just, I can't
Yeah.
fathom that.
What the beep is going on?
I know. And I'm not the person to say that it's all hormones either. I think
Right.
that can kind
Right.
of in all of my visits, I'm like, you are a whole person, you
Mhm.
know? But they shouldn't be negated. And that's one of the things that happens is like,
Mhm.
okay, well, it's probably just like your mental health, school is hard. Yeah, all that stuff
Mhm.
is true.
Mhm.
Oh, it must be, your kid. Yeah, kids wake us up at night and,
Mhm.
or, and so that's what happens a lot of the times is that they go down the list of treating things individually or looking at them individually and not as a whole person, not as the
Mhm.
constellation of
Right.
symptoms. And when we
Right.
honor hormone decline as the primary driver, then we can get some people can use hormones
Right.
as medication. And there's
Right.
other options too. now.
Mhm. Mhm.
I think it might be game time.
It is.
My brain,
It
my
is.
brain is full, and so I prepared a game for you.
You need a
and
creative outlet.
well, it's actually now the game is embarrassing because I know I already know the scores you're gonna get in the
He's
game.
gonna crush it.
This is gonna be like
Oh, gosh.
the biggest landslide since who was it? Simon. Simon was dominant
Oh yeah,
in
he
his game.
dominated.
Knew everything about shoes. Who else was good? Vu was
Dr. Vu was on
also
it.
a very strong force.
Yeah.
Yeah, here we go.
All right.
It's like, can we just pause and I'll make a different game that's like based on cartoon trivia or something like that?
I don't know. No pressure
All right.
now.
This game is called Myth or Menopause. It's true or false game, okay? So, yeah, I'm pretty much sure you're going to get all of these. Okay. So, true or false? Question 1. All women experience depression during menopause. True or false?
False, but mostly true.
Okay, yes. You are correct. It is false. They're very common, but not everybody does.
No.
Right.
And I think
We can't
maybe
say everybody about anything.
yeah, and I
Right.
think some people maybe miss it because maybe they got a girlfriend who that was their biggest symptom, and they're like,
yeah.
"Well, I'm not depressed," and so
Mm,
it's probably
mhm,
not perimenopause. Okay,
mhm.
good, 100%. I should have like March Madness is coming up, and this is a safer bet than
Yeah.
any of those teams.
Sport ball.
This is like a 16 versus 1 right here.
Yes.
Here we go. All right. Question 2. Hot flashes only last for a year or two during menopause.
No.
Not even thinking about that.
No.
one.
Some people
No.
are super flashers
Yes.
Oh.
Oh, wow.
where they never go away.
Oh, that's not
Ouch.
fun.
I know.
That's not fun. You know, I have some women who are perimenopausal, and when they get adjusted, instant hot flash.
Oh, yeah.
Interesting.
It's like,
Yeah.
oh my gosh, I
It's a
had
vasomotor symptom. So
Yeah.
you're like,
I had one patient in particular who's like, she would have to time her appointments because she knew she got adjusted. She'd have to go home and take a shower.
Oh
afterwards.
wow.
Yeah. I was like, hey, it's all good. I'm that powerful.
Yeah.
Not really. Okay. Question 3. Hormone therapy always increases your risk of breast cancer.
False.
Okay. And it sounds like it can do the opposite.
Yeah. Well, what I can say is that I can say with all confidence, if I put somebody on hormone therapy and they get breast cancer in the future, that it was not caused by the hormone therapy.
Yes. So association is not causation.
Yeah, there you
Correct.
Gotcha. All right. Question 4. Menopause causes inevitable weight gain.
No.
Okay, good.
Common. But
Common.
no. And aging, yes. Weight
Yeah.
gain.
It causes weight gain.
Yeah.
So let's go there first.
Well, and aging causes weight gain because you got to be more active, right? Like you get older and you're doing less, and there you go. Oh, goodness. Okay. Question 5. Sexual desire always decreases after menopause.
No. No, ladies.
I think that's great news. I think everybody's happy to hear that.
Yeah. But it can be common.
Okay.
Yeah.
Question number 6. There are no effective treatments for hot flashes besides hormone therapy.
Incorrect. False.
So what are some of the non-hormonal therapies that people can use for hot flashes?
Yeah, there are 2 non-hormonal medications that are fairly recent. They work on the KNDY receptors. One of them requires liver monitoring. The other one doesn't, but those are 2 of them. And then we can also use sometimes SSRIs or SNRIs, gabapentin, oxybutynin, but I am a Urogyne person and I...
Girl, you just like read the whole list.
Yeah.
Okay.
It's because I really am a specialist.
Yes, you're good at this.
She
All
is
right.
an expert.
Question 7.
Studies this.
We got 4 more here. Question 7. Vaginal dryness and discomfort will go away on their own after menopause.
No! And it's not a use it or lose it thing.
Okay.
That is a huge misnomer. Some people are told that if you keep blood flow to the area, that you will not experience hormonal changes at that tissue level, which is so not true.
And
Such
what a weird thought that would be what it is. It's like, just it's blood flow.
I think a man told a woman.
Absolutely. That was a
The
man
man
complaining.
keep the
first
blood
thing
flow.
was a man guessed, and so let me explain to you why that's true. It's my mansplaining voice. Question number 8. You can't get pregnant during perimenopause.
Oh no, it's true. You can't.
Surprise.
Yeah,
Yeah,
That's
I
why
know.
the IUD could be really good.
I know. I have some friends who hit the reset button.
Yeah.
I call it.
Ooh.
Surprise. Yeah.
I also
Surprise,
have
baby.
16 and a 1-year-old. You know,
Uh-huh.
not me.
Oh.
Somebody else.
Mhm.
Yes. Okay.
And tune in next time to find out. Question number 9. Black cohosh and soy supplements are proven to be as effective as prescription medications for hot flashes.
Incorrect.
Okay.
Nope.
What?
Nope.
Go ahead.
But what if they're from a supplement company that publishes their own white paper?
Oh,
Yeah.
it's so hard.
Yeah. But if the black cohosh is coming from a company that works through multi-level marketing,
Mhm.
that's more effective, right? No, I'm just kidding. All right. Final question. So far you've got 90%
Okay,
on this
cool.
quiz. Here we go. Most women spend about 40% of their lifespan in the postmenopausal stage.
Wow.
True.
You already get the
I
answer to
did
that
not
one.
tell you
Oh,
that.
see?
Nailed it.
Yeah, just absolute
Yay.
superstar. She's an expert, certified expert.
Okay.
Awesome. I
Yes.
thought I passed your test.
You
Yeah.
you can start putting the letters PTCH after your name.
There you go.
Yes, but it's got to go
certified.
Got to go right before the
Yeah,
ishwish.
yeah.
All right.
Sure.
Pitch ishwish. Okay, good.
Okay, so to wrap up, we usually finish with takeaways.
Takeaways. Yeah. Okay.
I want to hear your takeaways, Jason.
All right. So first of all, I'm shocked. I'm surprised. Okay. I'm gonna admit we talked about this beforehand, and Kathy's like, you can just sit there and listen, Jason. It's fine. Yeah, you'll survive this. But I've learned so freaking much. I think the biggest thing that I'm gonna take home and I'm gonna integrate is I am going to not shy away from noticing the connection between women who come in who have back pain, pelvic pain, what looks like SI joint pain. And they're also reporting things like dysmenorrhea or symptoms of perimenopause, because that is somebody who could potentially benefit from like a hormone replacement therapy. So, wow.
Yay!
Right?
Wow.
Yes,
I'm
we
leaving
have
her
a
a better
convert.
doctor. Oh my
We
goodness.
have a convert.
So good.
All right, Kathy, Smarty Pants. What about you? What are your take homes?
Well, every time I'm around Jessica, I learn something new. And so today, what did I learn today? Oh, I think what I learned today was that my menopause
Menopause took it away. Yes.
Just kidding. That we spend 40% of our life in menopause.
I don't.
Ish.
No.
We
Yeah. But
women,
yeah.
women,
Yes.
we-ish
Mhm.
women. Yeah. So that is a perspective I hadn't thought of.
That's crazy to think about.
It is,
huh?
isn't it?
And that's our menopause statistics. So if
Yes.
we include perimenopause.
Oh, right.
Yeah,
That's-
you're
we're
about
50%.
50%.
Yeah, that's a
Wow.
really good point.
I
Yeah, it is
just
50%.
came
Yeah.
up with that point.
Yeah.
So I'm gonna guess that it's not worth ignoring.
Yeah.
No.
Exactly.
Yeah.
Exactly.
Yeah.
Sounds good.
So just tell us, if you want to summarize what do you want people to know about you and your practice?
Yeah.
Yeah, and how do they like get in touch with you?
Mhm.
Wonderful. Yeah. So I am doing a telemedicine, cash pay, perimenopause, menopause, and sexual health practice. They can find me at GynJess.com. I'm also on the social media.
Can you spell that for
Yeah.
people?
GynJess.com.
Okay.
Yeah.
Good.
Yeah. GynJess.
And we'll-
Jess, tomato,
we'll-
tomato.
Pop it up on the screen, and we'll also put these links in the show notes.
Mhm.
Cool.
But, okay, so
Great.
GynJess.com, and then did you say there's an email or social media?
Yep. I'm
Okay.
GynJess on Instagram as well and on Facebook.
Okay.
Yeah. And then in our community, look out for educational opportunities with the Novo Collective. I do a few things. I love doing education around perimenopause, menopause, and sexual medicine because I do believe education is powerful. It's good to know what's going on with our bodies. That anticipatory guidance for the future is very powerful as well. So yeah, Novo Collective in our community here,
Mhm.
and then online, GynJess.
Outstanding.
Another outstanding episode.
Slow clap. Even Raul's over there clapping.
So good.
All
So
right,
good.
really appreciate it. I really
you
think
so
that
much.
Did we do it?
this was
Yeah.
fantastic.
This
Yes,
is so good.
I think that there's only like one little cherry
One-
that we could put
one
on
more
top,
thing.
and that is that there is no I in pitch.